So before the break, we were talking about how provincial governments can get better bang for their healthcare buck, so to speak, with Nadeem Esmail from the Frasier Institute. Nadeem, before the break there, you were chatting about Sweden and what they were doing in their experience with implementing activity-based funding. Could you sort of pick up on that point?
There is vast experience with the benefits of moving to activity-based funding. Sweden has done some very interesting studies. In Stockholm County in particular, they managed an 11% increase in total healthcare productivity with a 1% decrease in costs, and that was in part the result of a 10% cost decrease in the cost of procedures. County to county, counties that were provinces, I guess Swedish provinces that moved to activity-based funding, found they were getting about 13% more cost efficiency out of the hospital sector than provinces that had not moved to activity-based funding. And again, that's reflective of what we see in nation after nation that has made this change over the last 30 years. A greater cost efficiency, greater access to advanced medical technology, a greater focus on the patient, more efficient and faster care. The benefits are myriad, as you would expect when you dramatically change patients from a cost drain on the budget to now a source of revenues for the hospital.
So under this model, is there the potential, though, that it could lead to higher costs? I mean, obviously, governments have budgets. They have to be careful how much they spend each year. Under a model where we've got this huge backlog of surgeries, if a hospital really responded and started to really rapidly increase production being, the surgeries and services that they're providing to patients, could we see a situation where costs increase above what governments are spending right now?
I think it's certainly possible in the short term, but the reality is they're all people who need healthcare who would be treated anyways. And while they're languishing on waiting lists, they're going to deteriorate, which means more complex procedures, possible medical harm, the only cost-saving option being if they unfortunately don't make it to surgery or are no longer eligible for surgery. But that's not good healthcare. That's just poor quality of service. So certainly in the short term, I think there's the potential for that. What we see, though, internationally is that if this can bend the cost curve. There may be the possibility, based on some studies of select nations, that the rate of cost increase in the hospital sector tapers off. From the Swedish example, and certainly from the British example, and from what the OECD has seen, competitive bidding between hospitals can also bring costs down over time. That was the experience again in Stockholm, where there was a 10% cost decrease, which is what led to the 1% decrease in total costs with an 11% increase in productivity. So certainly in the short term, there's some cost concerns. We have to remember these are people who need healthcare anyways. At some point, they're going to get treated. We're just changing the timing of the expenditure. And by treating them sooner, we may be treating them more efficiently and more effectively, may need less complex services for them because they haven't deteriorated while waiting. And in some cases, those people might now be able to avoid death or avoid permanent disability as a result of more timely care. That's good health care.
When you talk about efficiencies and getting hospitals really focused on the care that patients want and need, it reminds me of a case from the Windsor Hospital in Ontario where they're running a Tim Hortons. So you have essentially the government running a Tim Hortons, and they lost over $2 million. And that's robbing patients of care, because that $2 million can't be used to provide hip and knee operations for those patients. So I can see how under the model that you're talking about, it really gets the system focused in on providing care to patients, because they're going to bring in more money when you actually get their hips and their knees done. I wonder if you could just touch upon, with about the next minute or so, what the end results are with patients. Like, is there a significant change in terms of customer service now that hospitals have the incentive to treat patients perhaps better because they represent funding coming in?
It really does all come down to the incentives, the high-powered incentives associated with attracting patients to the hospital. Today, it's in a hospital's interest to not attract patients to the facility. They make money on concession, although not at the Windsor Tim Hortons. They make money on parking, but every patient through the door will drain on the budget. So long waiting lists, beds blocked with patients who could probably move to another facility but aren't costing the hospital very much. OR shutdowns at 4:30, no ORs on weekends, summer and holiday slowdowns. These are all beneficial to the budget for the hospital as much as they're not beneficial to patients. These are no longer useful approaches when you have activity-based funding, because now the hospital wants to attract patients to the hospital. They want more patients through the door, more patients through the OR, more patients through the hospital beds. because that means more financial resources, more revenues. So now it's in the hospital's interest to reduce waiting times, to extend OR hours, to not have seasonal slowdowns, to make the facility more comfortable, more attractive, a concierge at the front door to welcome patients in, to help usher them out. By making the system more patient-focused, we improve customer service, but we also improve the quality of healthcare services delivered and the timeliness of those services.